Yeah, a debate between Dr. Jim Hansen and Dr. Phil O'Dwyer. I'm Roberta Payne, a counseling student here at Oakland University, and I'll be serving as your moderator. This debate is brought to you by the Counseling Department of Oakland University and is sponsored by the Graduate Counseling Student Honor Society, Chi Sigma Iota. This afternoon's debate is in the following format. Each speaker will have 20 minutes for an opening argument, setting out their point of view. Dr. O'Dwyer will speak first, and followed by Dr. Hansen. I'll then give each of them 10 minutes to rebut for a more spontaneous response to what the other person has said. For the final half hour, we'll open up the floor to the audience for questions, and each speaker will have a chance to respond to the questions presented. But one thing's for sure, we'll be sure to have a wide-range discussion on the DSM. Our first speaker today is Dr. Philip O'Dwyer. Dr. O'Dwyer is the president and clinical director of Brookfield Clinics in Garden City, Michigan. He earned his doctorate in counseling at Wayne State University. Dr. O'Dwyer is an adjunct professor here in the counseling department at Oakland University and is the chair of the MacDonald Lectureship Committee at the University of Michigan Medical School. Dr. O'Dwyer is a consultant to numerous national and international public policy organizations and currently serves as a member of Berkeley City Council. Please join me in welcoming Dr. Philip O'Dwyer.
Madam Chair, Dr. Hansen, members of Chi Sigma Iota, and distinguished audience. I come today to defend a book, a clinical practice, and a method of conceptualizing the emotional pain that torments the lives of those we are called to serve. This book is no new publication, but has been evolving from antiquity. In its present format, it has enjoyed a process of refinement for over 60 years. While its longevity is beyond dispute, there are no sacred cows that are above challenge. Even the Bible and our own Constitution have those who find fault with their content. But the task today is to discuss the proposition before us, the DSM-4, useful or useless. No doubt the assertion that the DSM-4 is useless, a proposition my opponent has undertaken to defend, is an extreme indictment not only of a publication, but of the entire mental health care delivery system. It is a claim that seems extreme on its face, but we shall await the reasoning that supports his position so that we can gauge how thin the ice is upon which he stands. Our ethics today require us to provide full disclosure regarding any financial interest in a publication or in a treatment procedure. Therefore, you should know that like the rest of the nation's clinicians, I use the DSM-4 every day in my practice. According to the Bureau of Statistics, we get a glimpse of actually how many people use the DSM-4 in their practice. The nation's 635,000 counselors, 595,000 social workers, 139,000 psychologists, 633,000 physicians and surgeons, 33,000 psychiatrists. In fact, the DSM is used worldwide by clinicians, researchers, policymakers, the insurance industry, national governments, among others. When I visited the University of Botswana some time ago, there it was on every counseling professor's bookshelf. It is used worldwide because it is almost a mirror image of ICD-10, which is produced by the World Health Organization. Is it any wonder then that CAPE standards require, quote, the knowledge of the principles of diagnosis and the use of current diagnostic tools for all students in mental health counseling programs, end quote. They do so because over 2 million clinicians in the United States and countless numbers worldwide use the DSM in their work every day. In other words, a thorough knowledge of this document is required if one expects to work in the mental health delivery field. The purpose of the DSM-4 is to provide clear descriptions of diagnostic categories that enables therapists, clinicians of all kinds, as well as investigators, to diagnose, communicate about, study, and treat people with emotional and behavioral problems. The DSM is useful for researchers and practitioners alike, without regard to their clinical orientation, and it applies across all treatment settings: inpatient, outpatient, partial hospitalization, private practice clinics, and the like. But who produced this document? Well, the publisher is the APA, which is itself an irritant for some people. However, the fact is that more than 60 organizations and associations contributed to its development. Let me list a few: the American Psychological Association, the American Psychological Society, the National Association of Social Workers, the American Occupational Therapy Association, the World Health Organization, the National Institute of Drug Abuse, the National Institute of Alcoholism and Alcohol Abuse, the National Institute of Mental Health, the National Center for Health Statistics, the Coalition for the Family, and the list goes on. This information is printed in the introduction to the DSM-4 for all to read. In other words, this document includes input from every sector of the mental health field, more than 1,000 people according to DSM-4. Despite all this, some clinicians talk about the DSM as though it were concocted by a handful of eccentric psychiatrists fumbling around in their ivory tower, imposing their half-baked ideas on the rest of us. Yet, it seems we are going to be asked today to believe that they are all wrong, and that we should return to a time when each of us could construct our own version of emotional and behavioral disturbances. Or even worse, to believe that mental illness and psychotherapy are both myths. Indeed, it was precisely to progress from that kind of cloudy thinking that with each edition of the DSM-4, an effort was made to reflect evolving scientific findings and offer clarity to clinicians and a working nomenclature for researchers. Occasionally, one hears a critic bemoan what they call the medical model, as though in itself it is to be shunned like the plague. The growing field of cognitive neuroscience, developmental neurobiology, and related fields almost daily report findings that support the biological underpinnings of emotional and behavioral functioning. DSM 1 and 2 used the psychological approach to diagnosis, which essentially is based on inferential cause perspective. It sought to infer that of what process was underlying the symptoms that were being observed. Essentially, it tried to describe the why of the condition, the presumed underlying cause. Needless to say, it fit the psychodynamic model, which was prevalent in the 1950s and 1960s, when clinicians theorized at will, but could get no more than 30% agreement on any diagnosis. Because of these major flaws, DSM-3 moved to the descriptive approach, which predominated in Europe and was used by the World Health Organization. Diagnoses were based on objective signs, symptoms, and natural history. Essentially, the what of the condition as opposed to the why. it makes logical sense to me to first figure out what the problem is, and then later determine why it may have occurred. This descriptive approach was continued in DSM-4 and is likely to continue in DSM-5. When the DSM-4 offers a useful categorical classification system that is practical. The specific diagnostic criteria for each mental disorder are offered as guidelines for making diagnoses. The criteria sets reflect a consensus of the current formulation of evolving knowledge in the field. Its categories are prototypes, and if a client's condition closely approximates that prototype, they are said to have that disorder. These disorders are, quote, not completely discrete categories with absolute boundaries, end quote. For that reason, the DSM-4 uses descriptions like not better accounted for by to communicate when overlapping symptoms are presented. To add further sophistication to the diagnostic process, the clinician is often required to assess the intensity of the disorder by using specifiers like mild, moderate, or severe. Clearly, it is a document developed by clinicians for clinicians and should not be used by untrained personnel. Psychodynamic clinicians were pleased with DSM 1 and 2, but the first draft of DSM 3 caused substantial opposition from this group because they seem to prefer a less clear and descriptive approach to the diagnostic categories.